I have one question to Pavan. Pavan, where was the corticotomy is done? Your anterior approach or a medial approach? Posterior medial.
It's anterior.
I didn't see the scar there.
We specialize in scarless surgeries.
Okay.
It's a 10 mm thing, so hardly
Okay.
it could be visible.
Good morning, everyone. We'll see another tibia non-union that refused to unite, and then let's see finally what we had to do to get it united. So this was a 45-year-old male who had a run-over injury by bus and suffered a circumferential degloving injury and open fracture of the distal tibia. So he was initially treated in an X-fix, which was kept for 3 months, and then once his wound was okay, they had skin grafted it, and at the end of 3 months, they converted the fixator to above knee cast first, and then below knee cast. On presentation, this was the picture of circumferential skin grafted condition and a non-union at the distal tibia. So this was, the orange arrow is pointing to some attempt at healing. Biology seems to be okay. Overall, frontal plane alignment was good, but there was 22 degrees of recurvatum at the non-union. He also had, the orange arrow here is pointing to the recurvatum. He also had this equinus, which is visible here. He was walking with the foot plantigrade, but if you can see here, the anterior talus is uncovered, and there is relative equinus between the distal fragment and at the ankle. And this equinus was leading to that recurvatum force at the non-union constantly. So the plan was to do a fibular osteotomy, put on an Ilizarov fixator, and since this was a stiff non-union, wanted to correct it gradually with the 6-axis device, and also add a heel ring to distract the ankle and correct the equinus. So the post-op X-rays, putting on the frame and the fibular osteotomy. I'll put on the hexapod to correct the recurvatum at the non-union. So first we distracted it, then corrected the angulation, and simultaneously started with the distraction at the ankle. So that's the distraction at the non-union, and then converted to straight rods. The thought process here was because it's a stiff non-union and some healing is seen, we treat it as a hypertrophic non-union with distraction. There should be regenerate formation at the non-union, and ankle distraction then continued. And at the end of 2 months, that's the comparative picture for the ankle distraction, and then we repositioned it under anesthesia to a plantigrade position and maintained it in that, and allowed weight bearing. Now, for the weight bearing, this heel ring constantly was giving him trouble. So we pulled it on for some time. And at 2 months, the regenerate was forming, but still there was a little bit of a empty area in the center. So we went ahead and did a percutaneous installation of GeneX, which is a bone graft substitute. The orange arrow is pointing to that GeneX. And at 4 months, seems okay. Some progress in healing, but not very convincing. But since weight bearing was getting hampered, we took out the heel ring and allowed him to continue with the weight bearing and see if things improve with that. But the equinus was returning. That was his gait at that time. Stiff ankle, not really getting any further dorsiflexion. So this was constantly putting some recurvatum stress again at the non-union. So at 6 months, we checked it under CM, and there was mobility at the site. So we did acutely compress under the CM. But since it was already in contact, again, just like what we saw in the previous case, the fragment started tilting. So now we have, earlier the frontal alignment was good. Now we have created some valgus. And we added exogen for whatever it's worth, the low intensity pulse ultrasound. But at 3 weeks, again, questionable healing, valgus, and the recurvatum reappeared. Equinus is worsening. So at that point, then we decided, okay, let's test it. And we left the distal rods loose for 48 hours. Initially walked well for a day, and then on second day he presented no pain, but he presented with a deformity. So now it's drifted further into valgus, some amount of recurvatum. So we put on the hexapod again because the pins and the rest of the fixator was holding well. So again, distracted and repositioned it and realigned. No further compression added this time to prevent that tilting. So now it's back in position, converted to straight rods, and allowed him weight bearing again. We were allowing him to stretch the equinus using floaters and straps, but he would not keep them on all the time. So at this point, probably compression is not enough, though it's all realigned well. And then at 15 months, again, some points it's healing, not fracture line still visible. And we took out the fixator and put him in a cast, followed by a brace. But over time, over a period of 8 months, he's drifted further into valgus, and the recurvatum has increased back to the same position, but now we have added valgus as another component from where we started. So around at 3 years now, that's the recurvatum on the left side and the equinus on the right side, which is the relative position of the foot to the distal fragment. So with this overlapped view of the clinical pic, the foot is plantigrade, but you don't really make out the equinus and recurvatum clinically. So now he has all problems. Valgus, recurvatum, the equinus continues. Now there's LLD as well. Initially he was around 1.2. Now he's around 2.5. And poor soft tissue cover, the deformities come back, biology questionable. So what next? Communication here was the key, constantly telling him of what issues are being faced and how best we can tackle it. So now this time we wanted to go all in and tackle everything. So for the non-union, we decided that we'll excise those ends, make the ends transverse, do central reaming, open the canal, do acute docking, temporarily fix the distal fragment with the transcalcaneal stand pin. Compression at the docking site will be aided now with excision of the fibula because of all that fibrotic tissue. Didn't want to take any chance with the oblique fibular osteotomy, lest it doesn't allow enough compression at the docking site and causes further angulation. For the biology, add in iliac crest graft, not only around the non-union site, but also in the interosseous space to get a cross union between the tibia and the fibula. Correct the equinus with the ortho SUV this time, and add lengthening because now we will be excising more bone and correct the LLD as well. So the oval arrows, ovals on the left picture are showing the excised fibular ends. The bone ends have been made transverse. The picture here is showing the transcalcaneal in putting the fragments, holding the fragments while we put on the frame. And this is the bone graft which is being added, punched in at the, to get that cross union between the tibia fibula, and the proximal osteotomy for lengthening. Zoomed in view of showing the orange arrow showing the bone graft. And ortho SUV was added later to correct the equinus, which was then gradually this ankle was distracted and brought back into repositioned into the neutral. This time we intended to keep the heel ring for more time, and the heel ring was then thus placed a little so that we could allow him weight bearing on the foot. So LLD sorted at 2 months of distraction, showing good contact at the docking site, and then continues to go on to healing uneventfully at 8 months. But we wanted to be doubly sure. In the interim, at around 5 to 6 months, we have taken out the heel ring, because then he was this was well on its way to healing. So did a CT scan to confirm the healing at the docking site, and from then just kept the fixator on for ample precaution and let the regenerate solidify. At 10 months, everything healed well, and the fixator functionally, there was some range at the ankle, and the fixator was removed and we protected in a slab initially and then gave him a brace. So at 2.5 years, it's all well. Shows ankle movement, but there is an osteophyte at the anterior aspect of the talus, which is preventing this further dorsiflexion. Though he is neutral to plantigrade and neutral to the overall axis, but if we consider the distal fragment again, there is a slight equinus still remaining. He continues to do well, no issues from then on. Showing just a comparative video. That's the left side is before the second surgery and protected in the brace, and now the right side is the recent gait. So a lot of learning points here. The distal tibia non-union, not only generally when we talk of alignment, we in tibia especially, we tend to say that sagittal alignment is not so important, but here the sagittal alignment was the key. So correcting that along with any stiff ankle deformities prevents any deforming force at the non-union. For the biology, the circumferential degloving had definitely some poor healing potential. We did get foxed with that extra bone which was forming. We treated it as a stiff non-union initially, that it would respond to distraction and regenerate should form, but it didn't really happen. So adding bone graft substitutes or any adjuncts like lipus really doesn't really work if there are other contributory factors. So Ilizarov crest graft there is a gold standard. The message we want to also give here is avoid procrastination. When things are not going as per plan, sit back, think, go through everything again, discuss amongst colleagues, find out what the real issues are and tackle it head on in time, and change your strategy accordingly. Stiff non-union, yes, distraction works to form regenerate, but now we tend to give it around 8 weeks to show itself that yes, is it well on its way to healing or not. If we find the healing is inadequate, then we will go in and bone graft the gap. Cross union in distal tibia non-unions, just like in CPTs, between the tibia and fibula, helps to increase the cross section of healing. And throughout this, communication was the key to take the patient through the rough waters, because it's a very long process, difficult situation as it is, suffering from the initial injury and then having had to go through all this process again. So the communication here was the key to keep the patients level-headed. Thank you for the patience.